Hi, everyone, and welcome to week 7. This week, we are going to be learning about psychiatric somatic symptoms and dissociative disorders. If you've had a chance to look over the PowerPoint first and read in your textbook, it would help you greatly to follow along with the lecture. So always make sure when I have these lectures posted that you do the reading first so that when I discuss a topic, you've heard about it before and you've already read about it. And now, when we discuss it in the classroom setting, it's driving home the key concepts. So, somatic symptoms and related disorders are a group of psychiatric conditions in which the individual has persistent somatic concerns, somatic meaning physical concerns associated with significant distress and impairment. This category is characterized by distressing somatic symptoms, which are combined with abnormal thoughts, feelings, and behaviors in response to those somatic symptoms. And if you follow along in your PowerPoint, you can take lecture notes if you want in your notebook, or you can just put this um, lecture on audio and listen to it in the car while you're driving so that it can kind of drive home all of these different talking points. So, individuals with somatic symptoms and related disorders are usually seen by physicians based on the basis of the physical symptoms, even though there's probably a psychological component. So, the person's going to the doctor complaining of IBS type symptoms, chronic heartburn, chronic stomach pain, constant diarrhea, cramping, headaches, body aches, joint pain, and they're treated as medical patients when really there could be a psychological component to that. So we're going to discuss somatic symptoms as a disorder, the illness, anxiety disorder, conversion disorder, factitious disorder, and other psychological factors that can affect medical conditions. And the one thing you need to know is that individuals with somatic disorders, they don't fake their symptoms. Their symptoms are real. Because they don't produce the symptoms intentionally or feel a sense of control over them, they may have trouble accepting that the symptoms have a psychological origin. So many people misunderstand the nature of somatic symptoms and their related disorders, so we need to separate ourselves from that. So, a myth: a patient with a somatic symptom or related disorder experience symptoms that are only in their head, when in reality, patients with somatic symptom disorders experience symptoms that are very real to them, and these symptoms cause a tangible degree of distress or impairment. So, converting that stress into symptoms. Somatization is an informal term used to describe the presentation of patients who have medically unexplained symptoms that cause a level of distress or impairment. Individuals with somatic symptom and related disorders, they internalize that anxiety, they internalize the stress, they internalize the frustration. And instead of confronting these feelings directly, it is thought that they express them unconsciously through physical symptoms instead. So it's not all in the head. It's important to remember that patients experiencing symptoms of somatic symptom disorder or related disorder are not told it's all in your head. Failure to recognize somatization and manage it appropriately can lead to frustrating, costly, and potentially unnecessary tests and treatments, as well as more distress for the individual. And there's usually coexisting disorders. Individuals with somatic symptom disorder, they could experience panic disorder. They have disorders that include persistent pain, may coexist alongside depression, and they also have an increased risk of suicide. And then how does culture influence treatment choices. As individuals' culture or ethnic background may influence their treatment preferences and choices, some cultures may be unsupportive of alternative therapies, whereas other cultures may often use alternative techniques. So, some patients who use complementary or alternative therapies are hesitant to disclose that if they fear that their healthcare provider is not going to support that decision or that intervention. Cultural norms and expectations can influence how people express physical discomfort. So, in certain cultures, it's normal for people to express pain outwardly, whereas other cultures might suppress those emotions. So, the relationship that exists between somatic symptoms and depression are very similar around the world, even between varied cultures within the same country. So, the pathogenesis of these disorders is not fully understood. Researchers have identified several factors that appear to affect vulnerability to these disorders. So, risk factors could be female gender, fewer years of education, lower socioeconomic status, personal history of a chronic childhood illness, a family history of chronic illness, or an existing medical or psychiatric condition. Developmental factors, a history of physical sexual abuse, difficulties with self expression, cognition, are accompanied by behavior abnormalities that have identified as factors accompanying somatic symptoms and related disorders. It is thought that an individual with one of these disorders experiences overwhelming stress without adequate coping skills to deal with the predisposing factors. Which individuals cope adequately or develop somatic disorders is thought to be influenced by personality factors, genetic determinants, environmental factors, and availability or lack of social support. Individuals who have the predisposing factors and do not develop symptoms, or who develop symptoms but quickly recover and return to normal functioning, are referred to as someone who is resilient. And behavioral theorists view psychosomatic symptoms as responses to a patient consciously learned and subsequently maintains because they bring some type of reward. So the symptom, for instance, may allow a patient to gain sympathy, gain concern, avoid unpleasant tasks, explain or justify their failures. And there's also heightened body sensations. Somatic symptom and related disorders may be linked to a heightened awareness of normal body sensations. So, paired with the cognitive bias, this heightened awareness may predispose the patient to interpret any physical symptom as a sign of a physical illness. An individual who is worried about physical disease may focus attention on common variations in bodily sensations, hunger, pressure, stiffness, to the point that these sensations become disturbing and unpleasant. The patient thinks the sensations confirm the suspected presence of a physical disease. The perception of the altered sensations exacerbates the individual's concerns, which further increases their anxiety and amplifies the sensations. So it could be a patient who has some knee pain and they somatically start culminating in their brain that that means that they have a tumor or they have cancer or they have, electrolyte imbalance or they have something that is anything else except for a knee that is just sore because it's sore. Individuals with somatic disorders may seek that sick role because it provides relief from a stressful interpersonal expectation. And in some cultures, they get attention and it's positive attention. So it kind of reinforces them to play this sickly role. And symptoms may be most obvious during early adulthood, but there are few patients are entirely asymptomatic and they can go 1 to 2 years without seeking any medical attention. Somatic symptom disorder often coexists with other psychiatric conditions like major depression and anxiety. These patients are an increased risk for substance use disorders, especially involving prescription medications, as well as drug interactions because they're getting prescriptions written by multiple providers. So we talked about causes. There's no specific cause. It's genetic, environmental, psychological. And signs and symptoms may involve any body system, but commonly involves the gastrointestinal system, neurologic, cardiopulmonary, and reproductive systems. Non-specific symptoms such as fatigue, dizziness, and syncope are often reported, as are pain symptoms. And it's not uncommon for patients to report multiple symptoms at the same time. So diagnosis of somatic symptom disorder can be challenging because the nature of this condition, healthcare providers must rule out all of the physical origins first. The patient will undergo physical examination, diagnostic testing to rule out physical conditions. When there is no specific diagnostic test that reveals this particular disorder, we can use a thing called a PHQ-15, um, which is the patient health questionnaire, and the somatic symptom scale, which is a screening tool that can be helpful in substantiating a diagnosis. So let's go over some of the common symptoms or common assessment findings that you are going to find in somebody with a somatic symptom disorder. So cardiopulmonary symptoms. Think about cardiopulmonary. What kind of symptoms do you think you're going to see in a patient with somatic disorder? It's going to be chest pain, dizziness, palpitations, probably short of breath, GI symptoms, abdominal pain, diarrhea, gas, intolerance to foods, nausea, and vomiting. We're going to have pain in the extremities, pain in the back, pain during urination, pseudo-neurological amnesia, blindness, difficulty walking, weakness, double or blurred vision. They could have dysphagia, dysuria, urinary retention, fainting, loss of consciousness, loss of voice, loss of hearing. They could have a seizure. For reproductive, they're going to have burning sensation in the sexual organs, dyspareunia or lack of pleasure during sex, impotence, sexual indifference, and then irregular menses can also occur because of the stress. Psychological evaluation should always be done to rule out a psychiatric disorder, such as major depressive disorder or schizophrenia, or an illness anxiety disorder. Ultimately, the diagnosis is confirmed if the patient meets the criteria in the DSM. And currently, we're using DSM-5. I know there's a DSM-6 coming out. It's on the DSM, which centers on the persistent physical symptoms that interrupt daily life and function. The manner in which the diagnosis is explained by healthcare providers is very important because we don't want to give the patient more distress and more embarrassment. It's very challenging to manage this type of disease. The patient may not acknowledge any of the psychological aspects or of the symptoms or be willing to consider psychiatric treatment. But the goal of treatment is to help the patient learn to control and cope with symptoms rather than to eliminate them completely. Telling the patient that symptoms are imaginary is not going to help them. It's very important to develop a relationship and a trusting therapeutic rapport with patients to validate feelings while also presenting them with factual information and supportive care. For example, as a nurse, you may say, "You don't have a serious illness, but I will continue to provide you care to ease your symptoms." So we have management, which we're going to focus on preventing unnecessary medical and surgical interventions, and we're going to turn the patient's attention away from the symptoms. Ideally, an individual with a somatic disorder should develop a long-term relationship with a trusted primary care provider, like a long-term relationship, not like a doctor shopping or going to like urgent care or minute clinics, that they actually establish care with a primary healthcare provider. So this is going to help guard against unnecessary tests, unnecessary treatments, possibly unnecessary surgeries. And it is best when the primary healthcare provider works in conjunction with a consistent and supportive, like interprofessional team. The key to success is communication between the provider, the team, and the patient so that we have consistency and we decrease the opportunity for unnecessary medical intervention. The interprofessional team works together. We support a healthy and adaptive behavior, and we encourage the patient to move beyond that somatization and work toward effective management of life. Like that's our goal. There's unclear evidence regarding the use of medication to treat somatic symptom disorder. If the patient has a coexisting depression or coexisting anxiety disorder, we could do SSRIs, so selective serotonin reuptake inhibitors, which may ease the preoccupation with the symptoms. Short-term anti-anxiety meds might be useful, only in like extreme cases. If we're going to use, benzos, we try to avoid benzos because they have the abuse potential. Um, our goal of pharmacological therapy by a healthcare provider is to only treat what is absolutely necessary and to taper and discontinue unnecessary medications. So, nursing interventions that are appropriate with somatic symptom disorder. We're going to acknowledge the individual's symptoms. We're going to support their efforts to function and cope despite their distress. We're not going to tell a patient that their symptoms are imaginary, but we do want to inform them of diagnostic test results and implications. We want to encourage the patient to keep a symptom journal. This validates what the patient's feeling, having the patient bring the journal with them to their next appointment and look for symptomatic patterns. It's very helpful in educating the patient and also increasing the feelings of control over their symptoms. And we're going to do strength in positive statements. Emphasize the patient's strengths. For example, say, it's good that you can still work even though you're in pain. This is very admirable. This is a good accomplishment. Help the patient make the connection of the link between stressful events and the onset of physical symptoms. Does visiting a certain family member make them start to feel sick? Like, do they work themselves up before they have to meet with a certain, coworker or boss or administrator? Keep in mind that your goal as the nurse is to help the individual find ways to manage symptoms, not eliminate them. Because patients seek medical care frequently with somatic issues, they often associate healthcare providers as their support network versus looking to develop a healthy relationship with family and friends. Work to establish a trusting therapeutic rapport, but fostering their independence by helping them strengthen their social relationships. So, we're always going to emphasize the individual's strengths and point out their accomplishments. So let's look at you as the student nurse, let's look at your attitudes. Also, you need to assess your own feelings and your own attitude periodically. If you think you've developed a non-therapeutic attitude, you need to acknowledge your feelings honestly. Be sure that your body language does not display frustration or anger toward the patient. Don't cross your arms, don't point fingers. Always keep your body posture where you don't look like you're disinterested in what the patient is telling you. It's important to remember that the patient really does believe that what they're feeling is real, even though there's no physical basis for the symptoms. Caring for these patients is very challenging for a nurse. So, care conferences, which could be like team or unit-based meetings, are a very important way to keep focused on providing the best possible care for your patient because you are part of that interprofessional team. And so I think I already totally blew past that particular slide, but illness anxiety disorder, um, there's a long history of previously unfounded health concerns that can contribute the healthcare provider overlooking a serious organic disease. So the individual is also at risk for complications from multiple evaluations, tests, and invasive procedures. So the prevalence of illness anxiety disorder is estimated to be about 13% of the general population. Illness anxiety disorder affects as many men as women. It does not pick a gender. Onset of illness is unknown, but appears to be more common in individuals between the ages of about 35 to 64. Illness anxiety disorder is considered a very chronic and relapsing condition. There's flare-ups often follow stressful events, and specific feared illness can actually vary. It's relevant to note that some cases of illness anxiety disorder are very transient and are associated with more medical comorbidities versus actual psychological comorbidity. So, in other words, some people, the disorder is less severe and does not last as long of a time. So, the exact cause is really unknown. There are numerous causative factors. So, psychological factors are thought to play a role in the development of this illness anxiety disorder. So, children may report physical symptoms that resemble those of other family members. In adults, illness anxiety disorder may reflect a wish to be taken care of by someone else. The condition enables the patient to take on a dependent sick role while another person tends to their needs. And looking at contributing factors, family member or friend that has a serious illness, reading about a celebrity's illness, having a history themselves of a serious illness. So, in older adults, illness anxiety disorder may be associated with depression or grief or loneliness. And signs and symptoms range from specific to general concerns. Usually, the patient reports multiple concerns over a minimum of about 6 months. The focus of illness may vary over that period of time, and the individual may have excessive contact with healthcare providers. They're care seeking, or they totally avoid contact, meaning they're care avoidant. So older adults may perceive themselves to be in poor health or at risk for poor health, even if they have no significant physical impairments. Their tendency to present with somatic concerns can pose a challenge to assessment and management. As a first step, the individual should undergo a comprehensive medical evaluation and laboratory tests to check for any physical basis. Cognitive and psychiatric examinations, are obviously warranted too. So, essential assessment data. When we assess the adult, we always want to gather a complete history. We're looking at past level of functioning, extent of their current abilities, the presence of any cognitive defects, signs of emotional distress. We're going to assess their psychological status. What's their living situation? What's their social support? What's their role with family? Do they have a key support person outside of the family? And to verify the individual's information, we should look at often, getting a collaborative history from family members. Be aware that family may respond to a patient's somatic symptoms by giving the patient more time and attention. So, in some cases, family members become angry and frustrated, and conflicts arise, and the conflicts escalate. The individual may even suffer from neglect and abuse. So, if you suspect this is happening, and we are mandatory reporters, so if you think that, um, especially our elderly, if they are being abused, that we report that to the authorities. All right, so multiple sources and details. Patients with illness anxiety disorder often focus on something specific at a given time, although their focus may change from visit to visit. So sometimes they will focus on a particular diagnosis like cancer, a specific bodily function, a normal variation in the function of a body part, and they'll have like vague somatic sensations. Typically, the individual describes the location, the quality, the duration in very specific detail, but the symptoms rarely follow any recognizable pattern of an actual organ dysfunction and usually aren't associated with any abnormal findings. So, examination and reassurance by a healthcare provider don't they don't often relieve a patient's concerns. Instead, the patient may report that the provider has failed to find the cause of their disorder. And we know that this actually does happen out in the real world. People are dismissed with their symptoms because the provider either thinks it's psychological or doesn't have maybe the knowledge of what tests or how to further explore what the patient is feeling, especially when we come into like the autoimmune world. So, just like a somatic symptom disorder, illness anxiety disorder is challenging. Patient symptoms change frequently and are often associated with normal body functioning. So, patients report of abdominal pain, which is diagnosed as having, you know, gas. So we have a complete history with an emphasis on current psychological stressors. We have to do tests to rule out underlying organic disease. We should not be doing invasive procedures unless warranted. And although history and physical findings may suggest an illness anxiety disorder, the diagnosis is official only if the patient meets the criteria in the DSM-5 determined by that healthcare provider. They have to have persistent preoccupation. I cannot speak correctly today. They need to be persistently preoccupied over a period of at least 6 months of having or acquiring a serious illness without symptoms being present. After medical evaluation is complete, the individual should be told by the healthcare provider that they don't have a serious disease and that continued follow-up will be designed to manage their symptoms. Linking the diagnosis to psychological stressors can be very therapeutic. Although providing this diagnosis may not make symptoms disappear, it can ease some of the anxiety. The goal of treatment is to help the individual improve their coping. Appropriate teaching and supportive therapeutic relationships with a trusted healthcare provider is very crucial for these type of patients. And they need their follow-up care, they need psychotherapy. There's really no pharmacological therapy to improve upon illness anxiety disorder. Certain medications can be prescribed to help patients manage symptoms, such as SSRIs or SNRIs. Medication can be helpful if there's an overlapping psychiatric condition like depression or anxiety disorder, but otherwise, psychotherapy would be your better choice. CBT, cognitive behavioral therapy, mindfulness, cognitive therapy, acceptance and commitment therapy, other psychoeducation can be very effective. So these type of patients do best when paired up with a therapist that they can build a good relationship with. So, nursing interventions, because there's a close relationship between somatic symptom disorder and illness anxiety disorder, nursing care will, of course, overlap. So, in addition to nursing interventions that we discussed prior, nursing interventions that are also appropriate for this type of patient can be providing teaching about anxiety disorder. Make sure we teach in a non-judgmental, very therapeutic manner. We want to help the individual expand coping skills. We want to assess the patient's level of knowledge about the effects of emotions and stress on their physiological functioning. We want to encourage the patients to express feelings to deter emotional repression, which can then have physical consequences. Teaching relaxation techniques. If your patient has symptoms related to stress or anxiety, relaxation techniques can help. So simple things like deep breathing, in which the patient takes a series of slow, deep breaths and releases after each one. Encouraging our patients to be deliberately mindful of the mechanics of breathing, which will divert their attention from other physical ailments and give them something different to focus upon. Teaching your patients how to perform the deep breathing, getting them into that comfortable position, having them close their eyes, telling them to focus on a peaceful sound, a peaceful image, breathing in through their nose to a count of 4, having them hold their breath for a count of 2, instructing them to breathe out through their mouth for a count of 6. And then they can repeat this for about 30 seconds to like a 5 minutes. There's no time frame here. Whatever works for that particular patient. All right. So I think that was enough on illness anxiety. Let's talk about conversion disorder. Conversion disorder, also known as functional neurologic symptom disorder. is marked by the loss of or the change in voluntary motor or sensory functioning, e.g., sudden blindness, sudden paralysis that suggests a physical illness but has no physiological basis. The symptom likely has a psychological basis, although we can't usually find it, readily identifiable right from the beginning. The conversion symptom itself isn't life-threatening and usually has a short duration. However, it's clinically significant and distressing enough, but because it disrupts social, occupational, or other important areas of functioning. The symptom isn't under the individual's voluntary control. This is an involuntary response. The patient with a conversion disorder doesn't feign or intentionally produce the symptoms, although they may have an unconscious motive of primary or secondary gain when they're doing this. So complications and consequences, conversion symptoms can severely impede the individual's normal activity. So the severity of the symptoms are comparable to what people who have the actual condition actually experience themselves. And then a part of this is that factitious disorder. Factitious disorders are conditions in which a patient deliberately produces or exaggerates symptoms of a physical or psychiatric illness to assume the role of that sick person. These disorders they're not malingering. Malingering is there's a clear benefit to why they're doing it. Um, Instead, this patient has a deep-seated need to actually just be seen as ill or injured. Patients may simply report symptoms or other methods, such as contaminating their urine. They might take hallucinogens, something to create symptoms. There's two types of factitious disorders. The first type is factitious disorder that's imposed on the self, and then there's the one that is imposed on others. So the term we used to use, but it's been changed, used to be Munchausen's. And then if you did it to somebody else, it was Munchausen's by proxy, but they changed the name. So it's factitious disorder imposed on another or factitious disorder imposed on self. If it's imposed on the self, the individual convincingly presents with intentional physical symptoms that are fabricated. So they have acute abdominal pain with no underlying disease. They're self-inflicted, that they deliberately infect a wound on their body. They could have an exacerbation of a pre-existing disorder. Someone who takes penicillin despite being allergic to it. They could take it, like, think your book here said something about person with type 1 diabetes takes higher doses of insulin, develops hypoglycemic crisis, then goes to the ED, doesn't disclose that the real reason they're hypoglycemic is because they took too much insulin. And so a patient with factitious disorder could have a history of multiple admissions in various hospitals, typically across a very wide geographical area, extensive knowledge of medical terminology, pathological fabrication, shifting concerns, shifting signs and symptoms, very poor interpersonal relationships, refusal of psychiatric examination, psychoactive substance or analgesic use, eagerness to undergo unnecessary procedures, even if it's high risk or painful, evidence of previous treatments, and then discharge against a medical device to avoid detection. Factitious disorder imposed on another, formerly called Munchausen's by proxy. In this type, the same patterns of behavior may be present in the caregiver versus the patient. So the illness is being imposed on another, who's the victim, by the person who has the actual disorder. The individual, it's typically a parent, intentionally produces or causes physical illness or condition in another person, which is usually a child, through actions like falsifying a child's medical history, tampering with laboratory tests to make a child appear sick, injecting substances, or exposing the child to toxic substances, tampering with treatments, playing with intravenous lines, changing ventilator settings, or actually mutilating a child. This diagnosis is assigned to the caregiver, it's not assigned to the victim. The victim may be assigned a diagnosis of abuse, but um, this is talking the individual performing the abuse is the one who has the psychiatric disorder. So it's usually not diagnosed in primary care. It's usually diagnosed in a secondary care environment, and it's seen in up to 20% of patients with who are seen in neurological psychiatric settings. Uh, Conversion disorders were once thought to affect more females than males. However, current evidence shows that certain symptoms are more prevalent in males, while other symptoms are more prevalent in females. Very few studies are available to establish a known age of onset, although it is extremely rare to find any documented case of a conversion disorder with patients like under 10 years old. All right. So in your book, they went over the different body sensations. I kind of talked on a lot of this already in the beginning. There's each of these different domains, so make sure that you read over each domain and how things can change based on like culture, based on location, spiritual, seeking peace because of negative thoughts and beliefs. Interprofessional disorders, we talked about how we take care of this. Cognitive behavioral therapy, I touched on already. Complementary and alternative medicine. Building therapeutic relationships is essential. Many patients have a sense of isolation or a distrust. Always be non-judgmental. Assessment, comprehensive presence of underlying medical conditions. Always assess for pain, anxiety, depression on all of your patients. Uh, this slide gives you different questions you can do in your um, patient interview. How long have you been experiencing this sensation? What has helped you in the past to deal with these? Have you had these sensations for, a long time? Did they affect your daily life? How is your family responding to these? All right. And then diagnosis and planning is based on presentation. Collaborating with the patient, most distressing symptoms are as identified by the patient. We had to plan goals around all the domains, and long-term goals will include learning and stress reduction. Make sure your goals are always measurable and achievable. You can't give goals of achieving something in 2 weeks that is probably going to take a patient 2 or 3 years. So always make sure you go back and you read when you're doing your nursing care plans, that you read the goal and make sure that it is measurable. Can we go back and how would we know the patient achieved this goal if it's not measurable? And then implementation, promoting safety, assessing for suicide, developing safety plans if needed. Although safety plans have now become a taboo subject in the psychiatric world, I still do safety plans because I've been doing this for a long time and I think that they work. Primary, secondary, tertiary interventions. Um, what are we doing? Primary, we're teaching about effects of anxiety. Secondary, we're doing detection and treatment. Tertiary, we're improving functioning of life and understanding illness. All your different implementations, patient education, always patient education, patient education. You'll see that on NCLEX over and over again. Just make sure when when you're reading a question and you are trying to choose an answer, and when you do NCLEX or any nursing style question, usually all four answer choices are correct in some way, but you have to pull apart what is the question asking you? Is it an assessment question? Because if it's an assessment question and one of the answers has to do with planning or implementation, then that's not the answer. You need to find the answer that gives you assessment data. So that's where a lot of people are making this transition who have done college in another specialty and then try to enter the nursing world. It is not, our questions are not cut and dry. And you'll do a lot better on these quizzes and on your final midterm and final exam if you start to really break down what questions are asking you. All right. So let's do a quick little quiz. How does the nurse document the manifestation of a physical symptom caused by a psychological distress? What's the word for that? And so your choices are, is it psychosomatic? Is it conversion disorder? Is it a pain disorder? Or is it somatization? And the answer would be that somatization occurs when a physiologic or a psychological state causes or contributes to the development of physical symptoms. The nurse is caring for a patient who's been diagnosed with a somatic symptom disorder. When teaching about this condition, what will the nurse provide? Your choices are your symptoms are all in your head. Regular visits with a counselor can be helpful. Certain medications will cure this type of condition. There is no chance you'll recover from this disorder. That one's a pretty obvious one that it would be counseling being beneficial to the patient. But think about why the other ones are wrong. We never tell a patient that it's all in their head. We never tell a patient that a medication will cure a condition because that is a be all end all. And when you're doing NCLEX style questions, all or none or every time or anything, or they're usually when you see like a statement that's super inclusive like that, it's usually the wrong answer. I mean, if we're trying to cure like, gonorrhea, oh, yeah, maybe we got some certain medications that can cure that. But when we're talking about psychological issues, we're not going to cure any condition. And then there's no chance you'll recover from this. That just sounds terrible. Why would we ever say that to somebody? The nurse is caring for a patient whose therapist has the patient physically say the word stop when a negative thought enters the patient's mind. How will the nurse document this technique associated with this type of CBT? So is it, um, oh, I already gave the answer. I gave the answer while I was reading it. Okay. Um, well, it's called thought stopping is the technique. A nurse is caring for a patient who frequently misinterprets body sensations or symptoms. Which disorder does the nurse anticipate? Is it malingering, somatization, conversion disorder, or illness anxiety disorder? And the answer is illness anxiety disorder misinterprets the severity and significance of bodily sensations with the symptoms of illness. All right. What else? All right. We talked about all of these. Jean Charcot. There's a, if you look up CMT as a neurological disease, she was instrumental in getting that as a diagnosis. All right, these are go over all the domains. All right, so I touched on a lot of this already when I talked about somatization. Benzos should never be used because they can actually increase the risk of somebody dissociating. If you have any questions, we started a new thing in the Moodle. Each week there is a like a discussion board that you can pose any like while you're reading through the text and preparing for your assignments, you can actually go and if you have a question like hey, well, I don't really understand, dissociative disorders. I'm reading that it can that there's different types like daydreams or whatever. Like I'm just really struggling to realize what dissociative disorders are. Post that in the box for the Q&A, because if you are struggling with a concept, another student's probably struggling with the concept, and then I can go in and target with like either a written text or I could put like a voice recording or even like a Zoom lecture. I can put something on there that kind of go over whatever the question is. But I won't know where your deficits are in your learning if you guys don't tell me, because this is a distance asynchronous education. So if no one asks me questions, I just have to make the assumption that you're understanding. So, talking about dissociative disorders, they are a marked disruption of the fundamental aspects of waking consciousness, memory, identity, your consciousness, the general experience and perceptions of oneself and one's surroundings. Dissociation is used as an unconscious defense mechanism to separate anxiety-provoked feelings and thoughts from that conscious mind. Dissociation is a common occurrence that can range from normal to pathologic. So when we talk about the normal types of dissociation, we're talking about, daydreaming. There's a thing called highway hypnosis, which is like a trance-like state you can get into when you're driving. Person getting lost in a book or a movie or a program to the point that they fail to notice time or their surroundings. But there is a sense of when it is pathological and it interferes with the person's life. So there's different types. There's DDD, which is depersonalization, derealization disorder. There's dissociative amnesia, and there's DID, dissociative identity disorder. So when you look in your book, try to kind of come up with a game plan of how you can remember what these different disorders are. Dissociation is not really fully understood. Dissociative disorders have been associated with like forgotten childhood traumas or repressed memories. And some experts believe that dissociation is a defense mechanism used by a child who experienced either like an abuse or a trauma. Dissociative disorders they're very rare. As much as the movies and Law and Order and those shows try to make them sound, they're less than 1% of the population. Symptoms usually arise suddenly. Um, they can arise gradually. This is why it's not very well understood. Many times they're very transient. And if they do persist, though, they can cause severe functional impairments. So several theories attempt to explain. Psychological theories are that they're a response to trauma or abuse, and then to cope with that trauma or abuse, the patient tries to repress the unpleasant experience. And if that repression fails, they dissociate. The patient separates the experience from the mind because it was too traumatic to integrate it. There's biological theories, and they're linked with that DDD. Researchers, they point out that this disorder shares a very key symptom is the sense of loss of one's own reality with certain neurological disorders like epilepsy or brain tumors. There are several psychologic or psychiatric disorders, and the effects of some drugs like barbiturates and hallucinogens and marijuana can cause dissociative behaviors. But it's mysterious and it's often a very misunderstood phenomenon. So, a myth, a person who experiences dissociation after a traumatic event can consciously control the dissociation. And in reality, dissociation and derealization occur because the traumatic event has overwhelmed the person's ability to cope using any other method. And the dissociations are beyond the conscious control. And the myth is that people in a dissociative fugue state believe or behave in a confused manner. And in reality, most people in a fugue state behave completely normal. So, according to the learning theory, dissociative disorders represent a very learned response of avoiding stress and anxiety. And with opportunity and practice, a person can become highly skilled at dissociating. This learned behavior of forcing the memory from awareness is very common in people who have a history of abuse. But because dissociative disorder can mimic a physical illness or another psychiatric disorder, the patient should always undergo a complete physical exam. Mental health professionals will obtain a careful personal history from the patient and the family. The interview should include questions about their childhood or adult trauma, abuse, and anything like blackouts or periods of lost time, like fugue states where the person travels away from home with no memory of what happened, unexplained possessions that were may have been purchased during one of these fugues or blackout states, relationship changes, fluctuations in skills and knowledge, unclear or spotty recollection of one's own history, and occurrence of spontaneous translate states or even like age regression. And patients with dissociative disorders, there's a couple different screening tools. There's like a Cambridge depersonalization scale that has like 29 different types on there. There's a multi-dimensional inventory of dissociation. I want to say there's like 218 items on that one, and it takes like an hour and a half to complete the interview with the patient. There's a dissociative disorders interview schedule. That takes about 30 to 45 minutes. It's a very precise, designated order of how you ask questions. And there's a dissociative enterprises scale. It's called the DES-2. It's a very brief self-report scale. They kind of quantify their experience for each item, and if the person scores above a certain number, then further evaluation then is necessary. And there's a diagnostic drawing series where like an art therapy thing can aid in the diagnosis of dissociative disorders because and I'm sure now that you've listened to this and Big Brother, devices are listening, you'll end up getting on your social media an ad for doing dissociative tasks of like looking at different artwork and saying, do you see like a tree or a lady's face? That is part of this, looking at drawing a tree and how, picturing your feelings. So art therapy can also diagnose a dissociative disorder. All right. There's some sample questions. Do you ever find that you've done things you don't remember doing? Have you ever looked in the mirror and you don't recognize yourself? Uh, we went over plans and goals. We did all the safety. All right. And that is the end of chapter 20. I hope you guys had fun listening. Please, 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 please go back and read in your textbooks, read the PowerPoint over again, do your practice tests, do your modules in HCI, do all the things that you need to do to be successful. And out of each of my groups, I usually have at least one that is interested in doing psych nursing.